It was we had a long talk awaiting us. But Professor John Boineau is one of us. He's here in the surgery department, also has an appointment in this department. And 40 years of involvement in cardiac electrophysiology. And as you'll hear from him, he's a real pioneer. He started many of what became the practice of cardiac electrophysiology today. That is mapping the electrical activity of the heart, ablation, the Wolff-Parkinson-White story, all of and the maze. I think they did also with Rick Schuster is here. All of that has his hand in it. So without further ado, we'll listen to
okay. This has to sound a little also for the thing. This is not the talk that I originally planned to give. I was asked to prepare this talk that I'm going to give today for a meeting called EP in Aspen. But the last minute, the Cleveland Clinic took over the meeting and assigned me another title. But I'd already prepared this talk, so I thought I'd inflict it on you and maybe practice a little bit. I'm going to show a lot of figures, but we're not going to spend any time looking at the details of the data in any of these figures. The idea is to look at the whole spectrum of things, because I want you to get the big picture of how we got from there to here. Most things that any of us do are sort of the result of very purposeful and directed kinds of work, and some accidents that take place, and some things we never intended to happen, but all become part of a sequence that probably is necessary to get to some next step to solve some other problem. Okay, I'm having problems with my slide here now. It's not wanting to get out of this mode here. There we go. This is my mentor, Matty Spock. He was here several weeks ago. You heard him. He and I started working in electrophysiology back in the 1950s. I was a medical student, and he was a resident in pediatrics, and we both had an interest in cardiology and electrophysiology. At that time, most of electrophysiology was trying to understand the abnormal electrocardiogram, and including arrhythmias, but also the abnormal QRS complex and STT waves. And this is sort of the first paper that I worked back on with him in 1960. Had trouble getting it published, as every paper I've tried to publish since then. But finally, Bob Grant, who was the chief of NIH, helped me get it published. When I started doing all of this, there weren't any pacemakers. There were no defibrillators of any kind. There was no such thing as clinical EP. There was no ablation. There were no cabbages. We had a few drugs. Most of those drugs were variably effective, very inconsistent. Some of them were obviously pro-arrhythmic, and we obviously killed some patients with those drugs. At that same time, the prevailing theory of arrhythmias was one of abnormal automaticity. This resulted primarily from the work of the people at Columbia after Silvio Weidman's work on the using the microelectrode in single cells, and everyone thought that all you really had to have was a very automatic or enhanced automaticity of a single cell to have an arrhythmia. But the people who really understood arrhythmias were all dead, and these were Jerry Mines, Schmidt and Erlanger, and these people in the late 1800s, early 1900s, and they were languishing in the forgotten literature, and I began to read them back in the 1950s and 60s, and thought they had a point. Gordon Moe, it seemed to me, was the one person who really resurrected the reentry concept to explain arrhythmias, particularly SVT, excuse me. So my questions were, could we identify a specific mechanism for an arrhythmia? And if we could, would it be focal or diffuse? And if it were focal, whether reentrant or automatic, could it be located and could it be removed, either surgically or removed or cauterized, without disturbing too much of the rest of the normal muscle? So the simple idea was that we needed a direct method for pinpointing the source of an arrhythmia, then we might be able to cut it out. At about the same time, Alan Schur in Seattle and Dirk Durer in Amsterdam had been studying cardiac excitation. And Maddie and Andy Wallace and I thought that the changes in ventricular activation might explain some of the abnormalities we saw in ECGs. And we were working on this in our labs there. We were doing studies to try to understand the basis of the abnormal cardiogram in RVH, LVH, bundle branch block, atrial septal defects, and myocardial infarction. And we developed epicardial and intramural mapping based on Schur and Durer's work, trying to understand this. These techniques, though, were easily transferable to the study of arrhythmias. This is Dirk Durer and his windmill in Amsterdam that the Queen gave. He died prematurely of prostate cancer, but he had a large impact on the early electrophysiology. One of the things that he found was that if you ligated the coronary artery in a dog and looked at the infarct electrophysiologically several weeks later, you saw fragmented conduction. And he was able to see these late potentials that you can see in the bipolar electrogram. This is the unipolar electrogram, which were delayed up to 50 or 100 milliseconds. So I had the idea that in an acute MI or in a chronic MI, that this fragmentation and delay could last for longer than 250 milliseconds. It might be delayed enough that it could re-enter myocardium and surrounding area that was repolarizing. Nobody else had been thinking about this. This was sort of a wild idea at the time. Everybody sort of laughed at it. This is Durer again out at his windmill where he's rediscovering uric, I guess. Dug this up on the side. So I asked Durer, could I come to Amsterdam? He had a lab and he was recording potentials to test this hypothesis. And he said, sure, come on over. And so I did. And on the first experiment that we did after getting there, we were able to demonstrate in an acute infarct with Gerrit Freud, who was one of Durer's students, delayed activation resulting in ventricular arrhythmias, and we're able to record that. We weren't able to do it consistently, though, and so I came back to Durham in about 1963, started working on methods to be able to do this consistently and systematically. So the data that I'm going to show you here is quite old. Most of you weren't born when we recorded it, so you won't probably have seen it. So I'm not too worried that it'll be too old. Anything this old is new. So we ligated the branches of the LAD, sometimes the proximal LAD. We developed and used in our lab intramural electrodes of various types that we stuck in the ventricle adjacent to the areas of infarction. And then we made recordings over time, and this is sort of what we saw. In the first, in the top, you see a bipolar reference somewhere in the right ventricle. After about 3 hours, it's unchanged, but the electrode in the infarct area, as you can see, starts getting wider and fragmenting and spreading out. And this was quite typical of infarction. And in some experiments, we were able to see that activation last quite long. The beginning of the tracing is the point of earliest activation, and so this electrogram, which is a local bipolar electrogram in the infarct area. It lasts for longer than 250 milliseconds. This is a series of cycles in a dog with acute infarction, and this is a bipolar electrogram recorded below with the reference above. And you can see the amplitude of the potential, how large it is. Suddenly, though, in this second cycle, the amplitude is reduced, and you begin to see a little sort of slur here. the amplitude in the third cycle is even further reduced, and this becomes even more obvious. Again, it is reduced markedly, and now these areas which we're activating at this moment in time are obviously being delayed here. And you can see the pattern of delay and the relationship between the change in the amplitude of the main bipolar potential and the fact that the late potential obviously is delayed from that original site. You can see actual Wikibach periodicity of these types of delays. You could even see alternation of these types of delays in some electrograms, 2-to-1 block. And here it shows the delay that occurs getting progressively later. Here are two areas of delay, finally getting late enough to actually generate a premature ventricular contraction, and two different examples of that. And this would go on to VTACH and VFib in some dogs, and of course that would end the preparation and end the study at that point. And this is what the myocardium, Jim Cox joined me later. This was all done back in about 1963 to 1965, and I tried to get the electrophysiology published, and I couldn't get it published. The people at Columbia didn't like it. It was not electrogram, cell related. And so I even went up there and gave talks at Columbia. I even gave them electrodes, and finally I got it published, but not until they got their chances to do the same thing and publish their own stuff. But this, later on, Cox joined me as a resident in the lab at Duke in about '68, and we did some histology, and this is histochemical staining of the tissue in this area of fragmentation, and you can see the areas that stain dark are viable. These areas that stain lighter are less viable or non-viable. And so this sort of suggests the following model for the desynchronization of activity. And if you have a coarse desynchronization, you have some delay in fragmentation. If you have a very fine desynchronization, then you probably have a circuitous route of activation through this thing, which prolongs the bipolar electrogram fragmentation. And later on, we carried this to patients. Once I had moved from Duke to California, we started mapping patients who had ventricular tachycardia. This is one of those patients. At that time, we couldn't initiate, because there was no program stimulation available, we couldn't initiate the VTACH, and so we had to map spontaneous VTACH, or we had to map VPDs. We had the VTACH morphology. And this is an example of one such patient. This is a normal activation. Normally, activation begins here in the mid-right ventricle paraseptally. This is the thinnest area of the right ventricle. Here is an area of very marked delay inferiorly and in the right ventricle. And then here is the area of the origin of the PVC. The assumption is that this late area feeds this early area, and that this is a reentrant VPD and a reentrant ventricular tachycardia. And by resecting this area, we were able to ablate the tachycardia. Hung up here on that. Let's get rid of that. These are 6 patients that we then went ahead and operated on in LA. In 5 of these 6, we were able to stop the ventricular tachycardia. These are the first 6 patients ever operated on for VTACH. And 5 of the 6 were successful. One of the patients, the one in number 4 here, ended up having arrhythmogenic right ventricular dysplasia, which at that time hadn't been identified. And we failed to stop her tachycardia. She survived the surgery, but about 2 months later, she died suddenly on the street in LA. This was our group at Duke. You'll maybe recognize me here. I don't know whether you will or not. This is Jim Cox, who was a resident in the lab at that time, Tom Daniel. This is Jack Castle, who I recruited to be the electrophysiology engineer tech. Bob Clark, who was the animal tech. And at that time, we were developing techniques to study normal activation and pathologic activation simply trying to understand the abnormal QRS complex and various forms of heart disease. The reason I mention this is because the techniques we used for that, we later used in mapping arrhythmias. And at that time, we worked closely with Neil Moore, who was a physiologist, a veterinarian from the University of Pennsylvania. And his group had a series of animals with naturally occurring congenital heart disease. And it was interesting to work with him because those animals weren't available any place else. We were able to explain several interesting electrocardiographic enigmas working with him. At that time, we were actually doing activation sequence mapping and body surface potential mapping. And this is one of the results of those studies. And this just shows an animal who has right ventricular hypertrophy. And what we learned from these kinds of studies, basically you could predict the activation sequence from the body surface potential distribution if you recorded it over time. Suggested that maybe if we were going to record the electrocardiogram in the future, we should not record scalar ECG leads, but we should record body surface potential distribution maps because we could deduce the activation sequence from those with just quite easily. Again, this is working in the lab with Neil Moore and some of the animal techs. I'm going to stop here for a second and talk about another arrhythmia, pre-excitation. This is a normal electrocardiogram for those of you who don't know what a normal ECG looks like. There is an APD here, but otherwise, and that's also fairly normal. This is a perfectly normal QRS complex. You can see the P wave followed by a narrow QRS complex followed by a normal looking T wave. This is an electrocardiogram of a patient who has WPW, Wolff-Parkinson-White syndrome. Should be actually called Wilson-Parkinson-White probably, but the basic underlying physiology wasn't known early on when this electrocardiogram was recorded. And people wondered why this QRS was very wide, why there didn't seem to be any PR segment between the P wave and the QRS complex. Another example of this same thing, this is the PR interval is short, the PR segment is non-existent. We have this slur, which has been called the delta wave, indicating an area of pre-excitation. This is also pre-excitation, but it is pacemaker-induced. Here we're pacing the atrium and pacing the ventricle at precisely optimal AV delay to produce the electrocardiogram that looks like pre-excitation. So this was known even before the mechanism of pre-excitation was discovered, and should have given us some hints as to actually what probably was going on. And again, that electrocardiogram would only be an interesting enigma of academic importance if it weren't for the fact that a lot of the patients had very fast heart rates at other times. And this is a supraventricular tachycardia in a patient who also has pre-excitation when he's in sinus rhythm. And this is just another patient with the same problem. And so it was this arrhythmia that let us begin to focus on the mechanism of the pre-excitation in the arrhythmia. Now, we were working with Neil Moore, and in addition to all the other animals that he had with the congenital heart disease, he serendipitously discovered a dog that had WPW. This dog came into his clinic, in veterinary clinic in Pennsylvania, because of a functional heart murmur. The dog belonged to the daughter of Dr. Wolfrath, who was one of the professors who wrote one of the early papers on Wolff-Parkinson-White syndrome. And this dog, we were able to get the dog from Mrs. Wolfrath, or whatever her married name was at that point, and we were able to study it. And you see there is a short PR interval with no PR segment. Here we have a slurred upstroke of the QRS complex, and this is a form of pre-excitation. Now, here we see the activation sequence on the anterior epicardium and posterior epicardium. And remember, the normal activation sequence begins here in the anterior right ventricle and spreads centrifugally. But in this dog, it begins on the posterior wall, right here at the base, the AV ring, and spreads away from that. And so in order to see what was also in this same dog, by simply vaguely stimulating him, stimulating the vagus, we were able to produce atrial fibrillation. And this is the atrial electrogram. And these are ventricular electrograms here, 3 through 5. And the atrial fibrillation spontaneously becomes ventricular fibrillation. The point is that it propagates directly across something into the ventricle. You can't do that across the AV node, as we all know, but it certainly did it here. Now this is that dog's heart. Here you see the posterior wall. This is the area of earliest excitation. We cut that area out. The area is cut out and you're looking at the bottom of it. Here we've turned it up. Here's the tricuspid valve. Here's the posterior septum joining the right tree wall. Here's the right atrium, coronary sinus. And we did 7 micron serial sections on that. Now before that, Kent had produced papers to show that there were these atrioventricular connections, which he felt were operative and actually competed with the His bundle and probably were part of the normal conduction system. He was laughed out of society, a scientist in London, because of this. And the problem was his histology didn't really go into where all the rest of the atrium was, and you couldn't see the definite details here of how these things connected. This is that dog, though, and you can see several cross sections here. Here we have the cross section in its size before enlarging it. Here is the area of the posterior septum. Here's the coronary sinus. Here are the atrial fibers inserting into the top of the tricuspid valve. Here are the ventricular fibers inserting into the bottom of the tricuspid valve. Here, though, we see atrioventricular fibers crossing the bottom or the limbus of the coronary sinus. Here you can see it even better. In retrospect, after we saw more of these in patients, this area right here is the coronary sinus, and this is the coronary sinus diverticulum, this little thing that you see right here. It contains those fibers. And therefore, we had the activation time here and here, and we were able to determine the propagation velocity across that connection, which resulted both in the pre-excitation and in the atrioventricular fibrillation. And here you can see it in greater detail. Now, we had the electrophysiology, but we didn't have the anatomy that I just showed you, when all of a sudden a patient came over from the coast of North Carolina. He was a fisherman, and he had pre-excitation, and he had supraventricular tachycardia, and he had a cardiomyopathy, a rate-related cardiomyopathy. And so we wanted to, if we could, abolish the area of pre-excitation we thought would be there. The other 2 members of our team wanted to produce AV block by blocking the His bundle. But I ran the lab, and I wasn't about to do anything like that. Because Dura had already shown a patient with pre-excitation that he had mapped in the operating room in Amsterdam. This patient was having an ASD repaired. He mapped it, he didn't do anything about it. He shows the early area of activation here. Later on, several months later, Burchell at Mayo Clinic demonstrated the same thing in a patient and injected lidocaine into the AV groove and temporarily abolished the pre-excitation. So it just didn't seem right to try to block or abolish the normal AV conduction pathway when probably we should be aiming at something else. So in order to do this, and even though we had been mapping for years in the operating room, we had never had to act on the data. We had never used data to do anything for the patient. And so in order to be able to do this and come out with data that we could use maybe to ablate the accessory pathway, we set up simulations of WPW in the dog lab. And for a week we practiced simulating pre-excitation and mapping so that we could get the technique down so it was fast enough that we could do it in the operating room without having to take all day. And so we placed different electrodes around the AV groove. We timed the AV intervals so that we would produce a pre-excitation like electrocardiogram, and then I would map around the AV ring and the rest of the ventricle trying to see whether we could locate a site of early excitation. The idea was not just to map around the AV range, but to map the entire ventricle in order to be able to see the coherence of the impulse moving away from a site, for example, a very localized early site, and expanding centrifugally. Now, we had another lab in addition to the dog lab above the operating room. You could look down from up here and see, so we set up a lab up here. We had one of the first score grants, it was called MyRU then, to study myocardial infarction in the operating room. But here we were actually, and this is probably what we were doing at that time. This is Jack Castle. And this is a couple of the technicians. This guy had to make the recordings, take the recordings off of the vesic water oscillograph. They're on tape, and make measurements on them. And since we did that offline for most studies, this study on this patient was kind of bizarre, because here we actually had to use the data, which we're measuring by hand, didn't have computers in those days, to try and make a map of the activation and do something about it in the operating room. So it was pretty chaotic. As you can see, we have paper all over the room, hanging over the lights. It didn't look much like science going on at that time. And this is the actual Polaroid photograph. We use Polaroid images to help the surgeon. And these are the actual activation times related to the atrial activation. And you see there is this earliest site of activation is here in the anterior right ventricle. And these later sites, you can imagine propagating away from that early site, sort of laterally into the rest of the right ventricle and then into the left ventricle. In fact, if we put an electrode at that point, that early point, and buried it in the AV groove, we recorded this electrogram, which actually shows an atrial potential, a ventricular potential, and this thing, which I think was a preventricular potential or possibly a Kent bundle potential. This is the map of the patient during pre-excitation, sinus rhythm, P wave, delta wave, pre-excitation. This is the area of earliest activation. You can see the wavefront spreading away from that. During supraventricular tachycardia, the activation begins normally in the anterior right ventricle and spreads in the opposite direction toward the AV groove, and then pre-excites the atrium at this exact same site that the ventricular site is pre-excited during sinus rhythm. And so it really gives you the focus of the area that you're going to have to ablate. And the surgeon, who was Will Seeley, simply divided that site, and the patient's pre-excitation went away, and his supraventricular tachycardia went away, and he had no more arrhythmias. This was the second patient we tried to map. This patient was a very complicated patient. Before we did the first patient, everybody was saying we shouldn't do all of this, that this was crazy kind of work. And then once we were successful, they immediately went out and found another patient with this type of activation sequence. It was very unstable pre-excitation, and during the mapping we could not definitely find an area of early pre-excitation. Retrospectively and later offline, we're able to identify an area right here of delayed pre-excitation. And that patient, we were not successful, failed miserably, and she actually died several days later in the post-op recovery room with intractable arrhythmias. And so at that point, everyone said, well, we should never do this again. All the people who said we should have done it before now said we shouldn't do it again. This just shows another map of a patient with that same type of pre-excitation, which is the most difficult type to correct. It's an anterior paraseptal. It begins up here in the sort of pulmonary conus region. The abnormal bundle runs very close to the His bundle, and even now we fail in doing some of those. But then we had a third patient who had pre-excitation of the anterior right ventricle, and having these anterior right ventricular pre-excitations, we were lucky because they were easily accessible, and we were easily able to divide them and convert them back into normal complexes during sinus rhythm, no longer pre-excitation, and no arrhythmias. And other patients too. This is a patient who has the earliest site of pre-excitation on the inferior RV here. We were able to divide that site too. Now we ran into problems when we started trying to do left ventricular pre-excitation. And this shows a patient, this is an anterior RV. You notice all these activation times are quite late. The earliest time is here in the posterior basal region of the left ventricle. And this patient we were not able to do from an epicardial site of ablation, surgical ablation. And this is the map pre and post-op, and you can see we really didn't change things very much. The site of pre-excitation is still there, and we failed on that patient. And for that reason, I felt like that we were probably approaching it the wrong way from the left side, and so I gathered several different anatomical specimens from pathology and dissected the AV groove because it really didn't understand the AV groove very well. And once I did that, I was able to conclude that we should be mapping on the inside of the heart and not just the outside. So we started mapping through a purse string suture in the left atrium on the inside, on the ventricular side, and on the atrial side. And then I demonstrated this to Seeley. I worked all this out in a patient, made a movie of it, took it to him. And so we started doing this operation endocardially, and we were able then to successfully ablate the left ventricular pre-excitation. Here's an example of a patient with left ventricular pre-excitation before surgery. The cardiogram here showing the pre-excitation. Here's the site where the obtuse marginal coronary artery. Here's a site of late normal activation. This is a fusion complex. You see here after the site of pre-excitation has been obliterated, here's the normal site of activation, and now the activation progresses normally from this site to the basal left ventricle, which is late. Now, during the middle of all this, we had WPW coming out of the radiators, and here I was reading a veterinary medical journal for some unknown reason in the Duke Library, and here in the middle of this journal was some electrocardiograms on squirrel monkeys. And one of those electrocardiograms is here, and what it demonstrates is pre-excitation. I don't know whether the vet knew that the monkey had pre-excitation or not, but it was quite clear to me that that's what he had. And so I called the vet up. He was at Winston-Salem, 75 miles from Durham. And I said, look, that monkey has pre-excitation, and would you give it to me so we could study it? He said, no, that monkey is in a study of atherosclerosis. And you can have him when the study's over. So I had to sweat out for about 6 months this monkey having a heart attack. but after 6 months, Jim, who was working with me at that time, and I drove over to Winston-Salem and brought the monkey back. And this is the map of the monkey. This is the right ventricle. You see there the pre-excitation here as you're looking at this little posterior inferior right ventricle. Here is that same side looking at the right ventricle anteriorly. But there was a second site in the left ventricle here. So here we have biventricular pre-excitation. So we did 7-micron serial sections, and this monkey's heart is so small that you can get the whole thing on one serial section. We're going to look at these two areas right here, the right AV groove and the left AV groove. On the right side, you can see these fibers diving down from the atrium into the right ventricle. The connective tissue is staining green. And here you see them even further down in the right ventricle. And here they're completely in the right ventricle now. And this is the site of right-sided pre-excitation. The left side, here is the great vein of Galen, the aortic valve, the top of the left ventricle, the bottom of the left atrium. There's nothing here in this slice, but in this slice here we have this big, broad, left-sided AV connection. So here in 2 animals and in several patients, we were able to demonstrate the anatomical substrate for the arrhythmia, both the pre-excitation and the arrhythmias that the patients and the animals had. I think those demonstrations of the anatomy and electrophysiology help others to go ahead and identify these same kinds of connections later in patients. Now, we began to try to develop new methods for mapping. And one of the methods we wanted to use was to employ more electrodes and record, if we could, up to 50 or 60 electrodes simultaneously on the ventricle to get a complete epicardial map within just a few minutes. in one heartbeat. And so we had some problems deciding how to apply the electrodes. And so we found this stuff called HygieNet, but we adopted it or adapted it for the ventricle. And it's elastic, and we use it to put these electrodes. And so this is the first recording of I think it was about 56 simultaneous sites of epicardial activation on a patient. And we started using this in California in about 1973. When we arrived in Georgia in 1974, about 76 or so, we developed the first digital computer mapping system. And these are electrograms that we recorded. These are all digitally recorded, and this is a system that we developed, Rick and I, with Kerry Miller, who was the electrical engineer, computer person back there. So we started doing computer mapping. Well, how does all this get us to the maze procedure? Well, in addition to mapping the ventricle, we were mapping the atrium for various reasons. And we discovered a dog who happened to have spontaneous atrial flutter. And here are electrograms and the ECG during two different types of spontaneous, naturally occurring atrial flutter in this dog. This is the typical type of atrial flutter, and this is the atypical type, which we termed type 1 and type 2. And these are the activation sequence maps. And here you see the activation going around the vena cava in sort of a clockwise direction as you view the atria posteriorly. This is the right atrial appendage, left atrial appendage, SVC, IVC, pulmonary veins. This would be anti-clockwise from the electrocardiogram point of view if you turn the heart around and view the patient from the front. And this was the type 2 atrial flutter, in which the activation was going in the other direction. The activation sequence is quite different as well. It was interesting that in that same dog during sinus rhythm, we found an area of very slow conduction in the mid-right atrium. You see the isochrones very close together. This is a normal activation sequence. For comparison, you see how rapidly the activation going down the crista is. And this dog had right atrial hypoplasia, which is sort of like arrhythmogenic right ventricular dysplasia in the right atrium. Here's this dog. Here are three normal dogs. Here's the crista terminalis, pectinate muscles, SVC and IVC. But this is the dog with atrial flutter and the slow conduction, which permitted the slowing in the reentry pathway and actually caused the reentry to be sustained, I think, and produce the atrial flutter. And the basis of the slow conduction is the anatomical hypoplasia. Well, we didn't really understand. We understood the role of slow conduction in the flutter, but we didn't understand how the reentry got started in the first place. And so we did a series of studies to try to understand the role of initiation and repolarization in initiation. So we did some studies in which we mapped the atrial refractory period. And this shows the atrium in which we mapped the atrial refractory period using S1, S2, the extra stimulus technique. And this is an area of very short refractory period. This is an area right adjacent to a very long refractory period. And if we put a premature beat in this area, we could get reentry. And we get reentry because what happens is the way, this is activation now. These A2, A3, and A4 activation maps, not repolarization maps. This is a repolarization map. You see the activation goes around the area of block, moves through all the areas of short refractory period, turns around and comes back into this area of late repolarization, and then re-enters the site which is right next to it, which is recovered earliest and is also the earliest to activate. And so this, we felt, was the way in which repolarization and homogeneity actually molded the wavefront and caused re-entries. And that was the first example of showing that correlation. During the middle of all these studies on atrial flutter and the initiation of reentry in the atrium, we found some interesting arrhythmias in which most of the atria seemed to be fibrillating or irregularly activating, but we had a path, a reentrant circuit which remained stable. And this was interesting to me, that we could have something very complicated looking like atrial fibrillation in the atria and the ventricles, ventricular response, and yet we would have areas in which the reentry seemed to be somewhat stable. And so we continued to look at that. We made different electrode plaques, and we came here using actual atrial anatomy to make these endocardial electrodes that you can see that fit in the atrium, and then we can record very high-resolution maps from the endocardium and the animal. And these maps really relate to all the different structures of the atrium, so you know exactly where everything is. That shows it anteriorly, the same electrode. We also use the same molds to make these epicardial potentials so that we could map the atria during atrial arrhythmias. And this is Barry Branham's software that he made to demonstrate our maps, and this is showing a stick-like three-dimensional structure. Later we projected the maps onto these things. We looked at atrial flutter. We found several different types of atrial flutter. We found that the orifices of the right atrium and left atrium are very important. We identified multiple pathways of reentry around orifices, which were quite interesting. But we also were more interested in some of the arrhythmias that looked like atrial fibrillation. We found one particular arrhythmia which looked for all the world like atrial fibrillation, with a small reentrant circuit in the left atrium. But the conduction time in the circuit was very, very short, but the conduction time in the rest of the atrium was much longer, and there were islands of non-uniform repolarization in the right atrium. And so what happens is you get dissociation of this flutter. Here we have a left atrial flutter. The area here, which is in pink, is all the same wavefront, and it's coherent, but there are two previous wavefronts from the two previous cycles. This is the next flutter cycle, but you can see now the purple and the yellow areas are still not out of the right atrium. And so what happened here is you get an arrhythmia which for all the world looks like atrial fibrillation, and yet it's a fast flutter. These are some maps that we recorded with Rick showing atrial fibrillation with wavefronts coming from multiple different sites, and although there is some commonality in some areas that you can see some repetition, most of it is somewhat chaotic. The point is that there are not an infinitely large number of different circuits here. So we developed two concepts for ablating AFib. When I was at Georgia, Jim came here as chief of cardiothoracic surgery. He asked me to come with him, and I said, well, I would go with him if we could do something that was really worth doing. And I had the idea then that maybe we should tackle atrial fibrillation. His mother had just died of a stroke from atrial fibrillation embolus, and I thought that maybe we could cut up the atrium into enough segments that it might stop fibrillating. So I began to listen to a lot of Vivaldi, and I read a lot of, look at a lot of the books of my stepson Kevin on mazes, and so I suggested to Jim that we might be able to cut up the atrium enough that we could stop atrial fibrillation. And so this was the thing that really allowed me to come to Washington, because I think if I hadn't thought that we could do something else, I would have stayed in Georgia. Rick would probably have never gotten here either, because Rick and I have been working together for about 30 years.
31.
Yeah, okay. It turns out that this was the first maze patient. His name was George Deere. We had worked this out in the lab. Jim and Rick and I had been able to stop atrial fibrillation in dogs. We used a model of acetylcholine infusion to shorten the atrial refractory period, because the previous dog models we had used, which were corti cuts trying to develop heart failure and left atrial enlargement, didn't work. And so we felt like if we could use acetylcholine, shorten the atrial refractory period enough, produce enough inhomogeneity of the atrium, we could get atrial fibrillation. If we could stop that, that would be the worst case. Now, it didn't resemble human atrial fibrillation, because it probably didn't have the conduction abnormalities that human atrial fibrillation did. But at least it was a model that we could work with. And so this was the model we tried. And this just shows a figure, one of the surgeon's figures of how badly the atrium is divided up here to be able to stop the atrial fibrillation. Now, we never really had any idea that it would work, but it did. It worked in the dog lab. And George Deere, the patient, heard about it, and he kept calling us. He's saying, I hear that you've been able to stop atrial fibrillation. I want you to, he was an airline pilot from Cyprus. I want you to operate on me and stop my atrial fibrillation so I can fly again. And Jim told him, well, we can't do that. It's just not, it's an experimental procedure. But he finally talked us into it. And he came, and he was the first patient. And he had the first maze, the maze 1. And we stopped this atrial fibrillation for about a year or two. And then he came back in atrial flutter, and then we ablated that. But that's sort of how we got started with atrial fibrillation procedures. We had the ideas not only for a maze procedure where we divide up the atrium into different compartments, but we also thought maybe there might be a better way of doing it, and so we had an idea that if we could actually divide the atrium and let impulses propagate centrifugally away from the sinus node, that we would not delay atrial activation significantly. We might have a better atrial transport function. And so we actually have moved on to do other types of atrial surgery with some of the Japanese investigators who were in our lab, Dr. Takashi Nida, and now he's performing this surgery in Japan. And this just shows a comparison of the two different operations, the maze on the left and the radial procedure on the right. They both work equally well. They both divide up the atrium into to a lot of different segments. They produce a very physiologic atrial activation in most cases, and sometimes the patient has to be paced. But they will stop atrial fibrillation. And as you know, this is sort of left the area of the surgical arena now, and the cardiac electrophysiologists are ablating this with catheters. And I remember one of the guys who was a friend when we were doing this back about 10 years ago, Sonny Jackman, came up to us in a meeting. He said, would you all really be taken aback if we tried to ablate this with a catheter? And we said, no, Sonny, not thinking you'd ever be able to do it. But now people are ablating atrial fibrillation with catheters, sort of indiscriminately in many cases, doing it sort of experimentally in patients without actually going through the normal sort of progression that I think one should go through with, that is, go to a dog lab, see if your procedure works, make sure it works out in the animal lab, and then take it to the patients. Nobody's doing that. And so there's some anecdotal approaches to this in which no two people are quite doing the same thing. It's also difficult to compare some of their results of different groups who are doing a lot of this, but it's become very popular. And if you or any of your friends have atrial fibrillation, I would warn you a little bit to have them stay away from the electrophysiologist unless you find one who you think maybe knows what they're doing. These are the people that I worked with over the years. I did leave one group out, and that was I was also at the University of Southern California in Los Angeles for about 3 or 4 years. And at that point, I was working with Ron Sylvester and Mike Village. Mike was the electrophysiologist there. He since has deceased, but he and Sylvester were very active in some of the work that we did out there when we left here. And so that's all I have. If there are any questions and we have any time left, we have the answer.
Who was your first surgeon in California?
Jerry Kay ran the Department of Surgery at USC, but he assigned a guy named Pablo Zubiati to do these kind of procedures. We started out doing double. And Pablo was a great surgeon. He was much better than Will Seeley was. And we did patients who had congenital heart disease, who would have Epstein's malformation, and replacing their tricuspid valves or correcting their tricuspid regurgitation, doing the accessory pathway surgery and closing very early on, quickly, a lot sooner than we would have had we been working with Will, I think. And then there was another guy that we worked with in that group who we did a lot of VTACH surgery with, who was in Jerry Kay's group. Yes.
What accounted initially for the difference in trying to find the activations in the ischemic tissue in the Boineau and Burns lab? Are there differences in electrodes or electrode configurations? Because it seems a lot of this requires a lot of technical advancement throughout the years too.
Both Schur and Dura had made intramural electrodes. Schur had made his out of tungsten wire, which they were much smaller, they caused less damage. Dura's were he used small hypodermic needles and then made holes in them and the individual electrodes through the holes and then up the barrel and then use some sort of cementing to fix them. So we used both of their different methods and developed our own techniques once we got back to Durham and made our own intramural electrodes. And most of them had 15 bipolar terminals, a millimeter apart. Some had 20 for the patients because they had thicker walls. And our technicians learned to build those, and we taught them at Duke and then again at Georgia. In fact, one of the technicians there still helps us build them from time to time. And one of the techs that we tried to get to come here, but we couldn't. And because her husband didn't want to leave, and she didn't want to leave him.
You've shown us the histology of the Kent bundles, but has anybody ever studied electrophysiology of them? Are they closer to atrial muscle or ventricular muscle?
They're both. I mean, you can see from the picture that the atrial muscle comes down and then inserts into the ventricle, and at some point, it probably, depending upon the anatomy, probably every Kent bundle is a little bit different. And some have more atrial muscle and others have more ventricular muscle. Some are very thin and circuitous, like the one that you saw in the right side of the squirrel monkey, and some are very thick. So it's a combination of the two, really. But no one has stuck microelectrodes into the Kent bundle to really look at the differences in the action potential and where it changes.
Could you do a biopsy or something, get it out and study the electrophysiology?
Well, yeah, I mean, you could now if you could come up with another animal model. If we find another animal model that had it, we could probably cut it out and impale it. It probably wouldn't tell you a lot. I mean, because the geometry determines probably more of what happens, the conduction velocity across it from antigrade to retrograde is very different. Sometimes the retrograde conduction is better because it has a better input signal going across backwards than it does from the thin atrium coming down. And so the geometry probably plays a major role, not only the thickness of it, but the fiber packing and density and all of that. It may be more important than whether it's mostly atrial muscle or mostly ventricular.
Did you follow up on the Maze 1 patient?
Yeah, well, he didn't have, after he had his ablation, he did not have atrial fibrillation again. But I understand he died of an MRI about 2 years ago. Isn't that right, Rick?
Yeah. Wait, yeah, I guess.
Yeah.
About 2 years ago.
I don't think he ever got back. I don't think they let him fly again.
No, he flew. He
Did he?
got his pilot's license.
He did.
back.
But he didn't fly commercially, though, did he?
Yeah, he flew.
He did?
He flew commercially for
Yeah.
Cyprus Airlines.
Well, he was a real success.
Yeah, the whole reason he
Yeah.
wanted the operation is he had to have something that was curative. He couldn't be on any medication.
Yeah.
And that was curative. And so he went back and flew for a while, and then he retired.
Any other questions? Well, thank you so much for sharing your attention.